First, cover the ulcer with dry gauze and secure with paper tape. If the ulcer is moderately draining, more layers may be necessary. Next, place small pieces of cast padding between the toes to protect the skin from maceration. The padding should only be 1 to 2 layers thick. Cover the foot and leg with a pre-sewn stockinette. Take care to remove as many wrinkles as possible. If wrinkles are present, cut a slit in the stockinette along the front of the ankle and overlap the material. Use adhesive foam to cover the toes. Cut a half-moon shape on one end of the foam and bevel the material. The foam should wrap around the distal end and cover the dorsum of the toes. Use caution not to pull the material too tight, for this may cause pressure. Trim any extra material around the front of the padding to give it a rounded shape. Again, the plantar aspect of the adhesive felt should follow the toe sulcus in a half-moon shape. Now cover the ulcer with an additional piece of adhesive foam. The foam should be slightly larger than the ulcer. Bevel the edges of the foam to reduce edge pressure. Place a felt strip on the dorsum of the foot and follow the line of the tibial crest. This will protect the bony prominence of the tibial crest from pressure. Tape in place. It is important that the holder maintains a 90-degree angle at the ankle during this process to prevent the padding from wrinkling and shifting out of position. Use one of the felt circles to pad the medial malleolus. Another pad is cut and placed next to the malleolar pad to cover the navicular bone. Tape in place. The last pad will be placed over the lateral malleolus. Note that the holder is careful to maintain a constant 90-degree position at the ankle. This ensures proper positioning of the protective padding. Once all your padding is in place, begin wrapping cast padding circumferentially, starting at the level of the fibular head and work distally. Apply 2 to 3 layers as you overlap the padding as you move toward the foot. Try to avoid wrinkles if possible. Because of all the contours of the foot and ankle, a continuous wrap may not be possible. Tear the cast padding and smooth the edge. Continue this process to cover the entire foot and ankle. Some edges of the cast padding may not lie flat. You can tear along the edge of the padding, causing the material to fray and smooth it with your hand. Because these areas are particularly vulnerable to shear and pressure, apply a few extra layers of padding to the back of the heel and Achilles tendon. Continue to apply padding with extra care to avoid wrinkles and imperfections, as these may cause pressure on the bottom of the foot during standing. Extend the padding just short of the distal end of the toe pad. Now, apply the Gypsona plaster to create a shell for the total contact cast. This is the most critical part of the cast, and the ankle must be maintained at 90 degrees without movement. Gently roll the plaster around the leg, beginning at the level just distal to the fibular head, removing wrinkles as you go. It is not a compressive wrap, so lay the plaster down gently without creating tension in the roll. Overlap the plaster by about 50%. This shell layer should cover the entire leg from just below the fibular head and extend distally to cover the edge of your adhesive foam toe cover. Do not cover the distal end of the toes at this point. This allows the holder to maintain proper position of the foot and ankle. Again, lay the plaster down without tension in the roll, allowing the plaster to conform to the contours of the leg. Gently rub the plaster with the palms of your hand and pads of fingers to remove any wrinkles and obtain total contact of the plaster on the leg. Allow 3 to 5 minutes for the plaster to dry. Gently tapping the plaster with your fingers is a good way to determine if the shell has hardened. Take precaution to not dent the plaster. Next, apply the plaster splints. Submerge the first set of splints and lightly squeeze out the excess water. The splint should still be saturated, and you can now work the plaster into the gauze mesh between your thumb and fingers until the splint reaches an even creamy consistency. The first splint is applied mediolaterally around the ankle. Any large wrinkles can be removed by cutting slits in the splint and overlapping the material. This is usually required at the heel and front of the ankle. Small wrinkles can be smoothed by gently rubbing the splint with the flat of your hand. The second set of splints is applied anterior-posterior along the back of the leg and extending over the toes. Smooth the splint on the back portion of the leg first so that the holder can maintain ankle position. Again, cutting small slits at the folds of the splint will allow you to smooth the material more easily. Once the back is smooth, the holder can release the toes and the end of the splint is wrapped over and around the distal end of the foot. Use your scissors to cut slits in the material to round off the front of the splint. The holder can maintain position of the knee at 90 degrees by placing the flat of the hand on the front of the splint. Use caution not to hold the splint too tight, as fingerprints may cause pressure inside the splint. Now remove the portion of the felt strip that extends beyond the trim line of the splint and reflect the stockinette back over the cast. Tug the stockinette firmly enough to roll the edges of the splint. This will round the trim line and reduce the possibility of edge pressure. Next, use one roll of extra fast setting plaster to lock in the shell and plaster splints. Extend this layer from just beyond the trim line to the distal end of the cast to cover the toes. Minimal overlap is needed. Cover the distal end so that no padding is visible. Work the plaster smooth as you go. Next, position the walking heel. With the knee at 90 degrees, visualize the plywood base in a position parallel to the floor to determine where the plaster filler will need to be placed. Use a second roll of extra fast-setting plaster to fill in the arch, forming the plaster base for the plywood to rest. Once enough plaster is in place, position the plywood and fill any gaps that are present with what remains of the plaster roll. Constantly check the angle of the plywood to ensure it is parallel with the floor from both the side and the front of the cast. With the plywood in place, set the walking heel in position. Attempt to line up the midpoint of the walking heel with the front of the ankle. For a longer foot, the walking heel may need to be moved slightly forward toward the toes. Again, check the angle of the walking heel to ensure it is parallel with the floor from both the side and the front of the splint. A level walking heel is important for balance and foot alignment when the patient ambulates. The final step is to wrap the entire cast in fiberglass casting tape. Minimal overlap is needed. This step adds structural strength and locks the layers together. Avoid adding too much material to the front of the cast, as this makes cast removal more difficult. Instead, use the last half of the roll to make recurrent turns along the sides and plantar aspect to strengthen the base and lock the heel in place. Wrap the entire cast with a compressive ACE wrap to mold the fiberglass until it sets. This will only need to set for 1 to 2 minutes. Mold the fiberglass tight against the walking heel to ensure it is solidly fixed to the base of the cast. Do not leave the ACE bandage on any longer than necessary, for it will adhere to the fiberglass and make removal difficult. Once the cast is complete, check for proper fit. First, check the proximal trim line to make sure there are no sharp edges that may injure the skin. Do this by running your finger along the space between the cast and the patient's leg. Next, check or excessive movement. You should not feel the cast moving up and down as you apply a traction force. And finally, check the angle of the walking heel. The patient's lower leg should be in a neutral position without excessive eversion or inversion. Using crutches or a walker, teach the patient a step-to-gait pattern and ensure they are safe and not at risk for falls. Instruct the patient to be partial weight-bearing and to only place 50% of the weight on the casted foot. This will maximize the offloading effect, reduce healing time, and minimize the risk of injury from the cast.
If you would like more information on Hansen's disease in our program, you can visit us at www.hrsa.gov/Hansen's-disease or call our toll-free number at 1-800-642-2477. Additional instructional videos about the evaluation and treatment of Hansen's disease can be found in the National Hansen's Disease Program Provider Toolkit located on HRSA Tube.